our speaker for today's Silver Symposium. She is a fellow of the Philippine College of Physicians, Philippine College of Endocrinology, Diabetes and Metabolism, Associate Professor for De La Salle Medical and Health Sciences Institute College of Medicine, member of the Internal Medicine Residency Training Committee, General Emilio Aguinaldo Memorial Hospital, and City of General Trias Doctors Medical Center. An active consultant, De La Salle University Medical Center, City of General Trias Doctors Medical Center, Korea, Philippines Friendship Hospital, and Tansa Specialist Medical Center. A visiting consultant in Silang Specialist Medical Center, South Imus Specialist Hospital, and St. Paul Medical Center. Let us welcome our speaker, Dr. Olivia Roderos.
Good afternoon. Before I begin, I would like to congratulate the DLS-UMC Department of Internal Medicine for this successful postgraduate course. The objective of this talk is to provide an overview of the American Diabetes Association Standards of Medical Care, updates on management of type 2 diabetes in non-pregnant adults. The Standards of Care is a 17-chapter guideline and is available online for free. I chose the topics that are most relevant to our outpatient practice. The main points of this talk are as follows. As we all know, diabetes is a prevalent disease, and the reality is that according to the International Diabetes Federation, almost 1 out of 2 adults with diabetes are unaware that they have diabetes. The study by Dr. Jimeno et al., involving 2 tertiary institutions in Metro Manila, revealed the high cost needed to manage people with diabetes in our country. Patients with poor glycemic control, with or without comorbid conditions, tend to spend more than those with good glycemic control. Hence, we all have to be proactive in managing our patients. Testing should be considered in adults who are overweight or obese and who have 1 or more of the following risk factors. Yearly testing for pre-diabetic patients should be done. As for patients with GTM, lifelong testing every 3 years is needed. An important ADA recommendation this year is screening beginning at an earlier age, 35, for those without risk factors. Last year, 45 was the age for screening patients without risk factors. Every person is unique. Assessment and management should be individualized. The goals of treatment for diabetes are to prevent or delay complications and to optimize quality of life. Patients need to be empowered via shared decision making. Patient diabetes education materials should be made available. Here at DLS MHSI, we have the Diabetes Education Center with the goal of disseminating relevant diabetes information. It is important to identify and address the patient's comorbid conditions. We have Mr. CM, a known diabetic for 10 years. He also has hypertension and dyslipidemia. He has no ASCVD, but he has chronic kidney disease. He also had albuminuria and elevated creatinine on a clinic visit more than 3 months ago. In case of Mr. CM and the rest of our patients, the ADA advocates lifestyle modification and diabetes education. Important also are the 4 pillars, which are glycemic, blood pressure, and lipid management, together with the use of agents with cardiovascular and kidney benefits. We should compute for the patient's eGFR and also check for urinary albumin to creatinine ratio, or UACR, at least annually. For Mr. KP, who already has albuminuria, we should check his UACR at least twice a year. Based on the heat map, he should already be referred to a nephrologist. Patients with chronic kidney disease should have controlled blood sugars and blood pressure. They should also undergo lifestyle modification. SGLT2 inhibitors are recommended to reduce CV events and CKD progression. Another option, especially for those who cannot tolerate SGLT2 inhibitors, is finerenone, a non-steroidal mineralocorticoid antagonist that also reduces chronic kidney disease progression as well as cardiovascular events. The ADA also recommends reduction of 30% or more on urinary albumin to reduce CKD progression. Finerenone was compared to placebo in a double-blind trial involving 5,734 type 2 diabetic patients with CKD. After a follow-up of 2.6 years, the primary composite outcomes of renal failure, a decrease of at least 40% eGFR from baseline, or death from renal causes, was 18% less in the finerenone group as compared to the placebo arm. Overall, the frequency of adverse events was similar in both groups. Significant weight loss can be attained with lifestyle programs that aims to achieve a 500 to 750 kilocalorie per day deficit. In the diet, there should be 14 grams fiber for every 1,000 kilocalories. Use of meal replacement plans prescribed by a trained practitioner can be beneficial. Medications approved for the treatment of obesity are shown in the slide. Please take note that there are two GLP-1 receptor agonists that are in the list. Liraglutide 3 mg being given once a day subcutaneously, and semaglutide 2.4 mg once a week subcutaneously. It is also important to note that there's no clear evidence for dietary supplements. Recently, an oral hydrogel marketed in the US as Plenity has been approved for long-term use in those with BMI greater than 25 to simulate the space-occupying effect of implantable gastric balloons. As for bariatric surgery, also known as metabolic surgery, it is a recommended option for selected individuals. Let us now talk about COVID. COVID increases the risk of new-onset diabetes via any of the following: steroid-induced hyperglycemia, stress hyperglycemia, and direct or indirect effects on the beta cells. It is recommended to have patients with diabetes be vaccinated against COVID using FDA-approved agents. What about NAFLD, or non-alcoholic fatty liver disease? NAFLD is associated with a 2 to 3-fold risk of developing type 2 diabetes mellitus. Both lipotoxicity and glucotoxicity contribute to insulin resistance, ectopic fat accumulation, and beta cell dysfunction. All patients are required to avoid excessive alcohol and to undergo lifestyle modification. There were many studies using different anti-diabetic agents for NAFLD. Clinicians should consider using pioglitazone as based on several clinical trials, it reverses steatohepatitis in patients with or without diabetes. Among the GLP-1 receptor agonists, semaglutide has the best evidence for benefit. Let us now talk about glycemic targets. The latest ADA guidelines advocate different treatment goals for different categories of elderly patients. According to ADA, Continuous glucose monitoring, as shown, should be offered to adults on multiple daily insulin injections or continuous subcutaneous insulin infusion. The choice should be made based on the patient's circumstances, desires, and needs. Please refer to the ADA document for detailed discussion on diabetes technology. For those with end-stage chronic diseases, with severely impaired functional status, and with reduced life expectancy, the goals are different. Reliance to HbA1c is not advised, and the goals are avoidance of hypoglycemia and symptomatic hyperglycemia. Here's an example of CGM result showing the glycemic excursions. A 14-day time in range assessment can provide a surrogate for A1C for use in clinical management. Individualization is key, even for non-pharmacologic management. In general, a 7% loss of initial body weight is needed, as well as an increase in moderate intensity physical activity such as brisk walking to at least 150 minutes per week. The patient's current eating patterns, preferences, and metabolic goals should be considered. It is important to note that more intensive dietary energy restriction can substantially reduce A1C and fasting glucose and can even promote sustained diabetes remission through at least 2 years. What is diabetes remission? It has been defined by ADA as return to A1C less than 6.5 that persists for at least 3 months in the absence of usual glucose-lowering pharmacotherapy. This slide is a favorite of mine, and it states that ingestion of sugar-sweetened beverages results in weight gain and obesity. Metabolism of high fructose corn syrup or sucrose increases insulin resistance and causes dyslipidemia, aside from increasing uric acid levels. So the end result is diabetes and cardiovascular disease. So what should be done now? We should replace sugar-sweetened beverages with water. Let us now discuss pharmacologic management. This is the classic slide by Dr. DeFronso showing the different organs involved in the pathophysiology of type 2 diabetes mellitus. First-line therapy depends on comorbidities, patient-centered treatment factors, and management needs. It generally includes metformin and lifestyle modification. For patients with ASCVD or those at high risk for ASCVD, the ADA recommends that either an SGLT2 inhibitor or a GLP-1 receptor agonist with proven benefit be used. Indicators of high risk are as listed. Age greater than or equal to 55 years plus one or more of the following: left ventricular hypertrophy, coronary artery stenosis greater than 50%, carotid artery stenosis greater than 50%, lower extremity artery stenosis greater than 50%. For patients with heart failure, SGLT2 inhibitors are the preferred agents. These are the different GLP-1 receptor agonist diabetes clinical trials. As shown in this meta-analysis of the different clinical trials, the GLP-1 receptor agonists with cardiovascular benefits are liraglutide based on the LEADER trial, semaglutide based on the SUSTAIN-6 trial, albiglutide based on the HARMONY trial, dulaglutide based on the REWIND trial, and efpeglenatide based on the Amplitude-O trial. As for the SGLT2 inhibitors, it is a known fact that they are the preferred agents for heart failure, the details of which have been discussed in the other lectures. For patients with CKD, the drug of choice will depend on the presence of albuminuria. In patients with CKD and albuminuria, SGLT2 inhibitors with evidence of reducing CKD progression are preferred, and if they are not tolerated or are contraindicated, GLP-1 receptor agonists are recommended. For patients with CKD without albuminuria, a GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit is recommended. The rationale for this is that diabetic patients, even those with CKD but without albuminuria, are at high risk still for cardiovascular events. We have here the different SGLT2 inhibitor trials. The last ones in the list, which are SOLOIST and SCORED, are the trials for sotagliflozin, an SGLT2 inhibitor that also inhibits gastrointestinal SGLT1. Sotagliflozin is not yet approved in the US, but is approved in Europe for the treatment of both type 1 and type 2 diabetes. Shown is a forest plot on GLP-1 receptor agonist and renal endpoints. We see here that most GLP-1 receptor agonists have favorable renal effects. May I just mention that aside from the trials shown, there are trials for obesity. The STEP or semaglutide treatment effect on people with obesity, and the SURMOUNT trial on the newest kid on the block, tirzepatide. Shown in the slide are the drugs that we can use to minimize hypoglycemia. DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, thiazolidinediones, and selected sulfonylureas and basal insulins. To promote weight loss, GLP-1 receptor agonists and SGLT2 inhibitors are the drugs of choice. In the Philippines, where cost and access to medications are issues, insulins with the lowest acquisition costs, sulfonylureas, and thiazolidinediones are recommended. Our patient, Mr. CM, is obese, and his HbA1c is elevated. Though he does not have heart failure, he has chronic kidney disease. Options for his condition will depend on the availability of financial resources. Surely, he will benefit from an SGLT2 inhibitor and a GLP-1 receptor agonist. Due to his GFR, which is below 45, his metformin dose should be reduced. At this point, let me just share that ADA advocates GLP-1 receptor agonist over insulin when possible. If insulin is used, combination therapy with GLP-1 receptor agonist is recommended for greater efficacy. This year, a new diabetes drug has been approved, tirzepatide, a dual glucose-dependent insulinotropic polypeptide glucagon-like peptide 1 receptor agonist, also known as twincretin. The combined actions of the two incretins, as shown in the slide, makes tirzepatide a potent glucose-lowering agent that induces weight loss. The SURPASS trials studied tirzepatide for the treatment of diabetes, the details of which are beyond the scope of this lecture. As mentioned earlier, the SURMOUNT trials studied the effect of tirzepatide on obese patients. Before the end of this talk, let me just share what we can expect in the coming years. The project of the ADA and EASD, or European Association for the Study of Diabetes, which aims to establish consensus and ultimate clinical implementation of precision medicine for the diagnosis, prevention, treatment, prognosis, and monitoring of diabetes. Indeed, diabetes is a complex disease whose management continues to evolve. Aside from keeping up with the latest developments, let us not forget to go back to the basics and be holistic in managing our patients with the goal of preventing complications. We should be aggressive in managing overweight and obesity. And last, but definitely not the least, advise our patients and even ourselves to avoid sugar-sweetened beverages and drink water instead. Easier said than done, but that is what is ideal. Thank you very much and have a great evening ahead.
Thank you very much, Dr. Roderos, for a very comprehensive discussion regarding diabetes. So, as a summary, we need to be proactive in managing patients, and it is recommended to screen all patients aged 35 years old and above. So, and we have to do yearly testing for patients with pre-diabetes, and patients with CKD should optimize glycemic and BP control. And lifestyle modification is important in patients with diabetes to diabetes remission. Thank you very much, Dr. Roderos. Let us now proceed to our question and answer. First question is that, is there a preferred COVID vaccine for DM patients?
Um, According to the American Diabetes Association, the ones that are preferred are the mRNA vaccines. Those are manufactured by, if I may mention some names, Pfizer, Moderna, and also the vaccines from Janssen and Astra.
So how
Yeah.
often do we check CBG in DM patient who is insulin
Well, it
dependent?
depends upon the level of control. If the patient is, the patient's blood sugar levels are well controlled, we may, actually, the main point of my talk is about individualization. So there's no hard and fast rule as to how many times, but usually in the hospital, of course, outpatient yung pinag-uusapan
Yes po,
natin.
outpatient po.
As outpatient, sa hospital lang natin premiums and at bedtime. Well, usually, if not well controlled, but there's no hard and fast rule, but I usually request 3 times a week. So that's my personal opinion regarding.
Okay po.
But I would just like to mention that the ADA recommends continuous glucose monitoring for those on insulin. Okay, kasi A1C is a good marker for control, but with CGM, we can see the hypos and hypers or hyperglycemic events of the patients. And it is important that we know when the blood sugar levels are going down, because hypoglycemic events can precipitate arrhythmias and other cardiovascular events.
Okay po. Next question po. Is it safe or okay to drink carbonated water or soda which is labeled as 0 calories in patients with diabetes po?
Okay, so we're talking about calories, no? I don't think it's bad, but of course, plain water is still the best, because carbonated water isn't pure. Okay. Yeah, and if I may state this, there's an article that came out last 2012, medyo matagal na, and it stated there that diabetes can be prevented. 7 to 8%. There's 7 to 8% uh, prevention of diabetes if we substitute water with sugar sweetened beverages. If there are 2 points that I would like to share for this talk, of course I mentioned 4, no? The first one really is to individualize uh, um, and our treatment, our management of our patients. And one thing more is to replace sugar sweetened beverages with water. And of course, the third one, if I may add, is let us be a little weight centric. Hindi lang tayo about glucose control, because with obesity comes mortality, cardiometabolic disease, non-alcoholic fatty liver disease, and kaya kasi wala ring non-alcoholic MAFLD dun sa ADA, hindi pa nila accepted yung term, but of course we all know that there's a thing such an entity as that metabolic associated liver disease.
Okay po. So next question po, is micral test sufficient in determining albuminuria in CKD patients, particularly diabetics?
I'm not a nephrologist, but it is not what is advised. It's what is being advised is urinary albumin to creatinine ratio, because it's, I think, more accurate, and it factors in the creatinine of the patient. So it's more if I may say, it's more specific for showing a renal dysfunction. So better to use, ang problem lang is the expense. So if for those who have HMOs, very easy to order. But for those without, it costs I think 2,000 to 3,000. So hopefully ma-lessen yung cost.
Next question po from the chat box. Is the oral GLP-1 agonist semaglutide approved by the US FDA last 2019 already here in the Philippines? Or can we expect it to be here within the next few years? What are your thoughts on the development of oral GLP-1 agonist?
Okay. As far as I know, it's not yet available here. And as for my thoughts, it's a good development that we have an oral agent, because one factor that prevents patients from really adhering to therapy, or even allowing themselves to be prescribed on, would be the cost, and the fact that the patients would have to inject themselves. So an oral agent is a welcome development, and I expect that it will be available in 1 to 2 years time here in the Philippines.
Here in the Philippines. Okay po. Next question po. What is the current recommendations for the management of pre-diabetes?
Okay, so the management of pre-diabetes is basically centered on lifestyle modification. Okay, so again, it's a diet that one can adhere to, and then the target weight loss is 7%, but better if 10%. Okay, in fact, for NAFLD, better if 10%. Okay, ang weight loss, and then of course, there's a study, DPP, the Diabetes Prevention Program. Okay, so yun pa rin basis ng mga studies for diabetes prevention. Like exercise 150 minutes per week, okay, total. And then of course pwede rin yung combination ng aerobic and resistance training, pareho rin daw naman ang effect noon. And at the same time, behavioral therapy, so dapat ang pasyente is really motivated. And what else? Now, metformin. So as for the role of metformin, usually for the obese patients, middle-aged, and those with FBS greater than or equal to 110 and A1C greater than or equal to 6. So we should give the patient metformin in the absence of contraindications.
Okay po. So madami po tayong questions, Doc. Another question. In patients with good glycemic control while on SGLT2 but with recurrent UTIs, what would be the approach?
Okay. Of course, if that, of course, you have to give antifungals, giving the patient, prescribing the patient SGLT2, an SGLT2 inhibitor. You try to advise her, usually her, to a single of UTI is not a contraindication to an SGLT2 inhibitor. But if it's recurrent, that's the time that I would rethink.
Change na lang.
I would think of other choices. But again, when we manage our patients, it's benefits versus the risks. Mamaya I will talk about a little hypogly. Sige na.
Okay po, Doc. So another question po. My patients frequently ask me regarding the sugar sweetened beverages. Do this offer an advantage in sugar control for diabetic patients?
Yes, they do. But again, I prefer natural. Of course, sweeteners are safe. Most of them are safe. But of course, you have to reduce also your calorie intake. Okay? So, whatever that you can adhere to well. So, ibig sabihin, kung ano yung masusunod mo. And I'm thankful for the lecture of Dr. Bernardino, because I think some of the questions that I may be asked, they were asked sa kanya na. Okay.
Sige. Another question po. Can you recommend the use of metformin for patients who are at risk or who have insulin resistance due to PCOS or obesity but have normal sugar levels at the time of testing? Thanks, Doc.
Yes, but there are many other options. Okay, the first, there are guidelines from different organizations. So that's beyond this talk. But first and foremost is lifestyle modification. Metformin isn't bad, but it does not promise everything. One has to really lose weight in order to reduce insulin resistance.
Okay pa. Sige. That's it for our question and answer. If you have
Thank the sponsor of this activity, LRI Terra-Pharma. Okay. And regarding hypos, no?
Apo.
Sorry, nag-extend ako ng konti.
Okay lang po.
Regarding my talk, no? I introduced many drugs, no? Some of them available, some of them not available. But we are here in the Philippines, so we try to make sure that the patients will be able to take the drugs that we prescribe regularly. What's the use of prescribing if the patient will not adhere? Well, okay. So there are many other options. Medyo nag-focus ako sa SGLT2 inhibitors and GLP-1 receptor agonists. But cost is an issue. We have other options, and even the SUs that have less hypo, such as glycoside, and the TCDs. And then TCDs also good for non-alcoholic fatty liver disease. And of course, semaglutide is a very strong drug, but the expense is. And if the patient would promise to comply despite the cost, that would be good.
Okay po. Doc, may pahabol pa pong question. Should we consider a patient diabetic with a normal FBS but with an HbA1c greater than 7?
Not yet. Of course, you have to repeat at the test, okay? And also, you have to make sure that the A1C, the laboratory, the technology of the laboratory is NSGP certified, okay? So we have to do repeat testing. But if a patient has polyuria polydipsia weight loss plus an RBS of greater or equal to 200 milligrams per diem, you have to single testing, we consider the patient as diabetic already.
Okay.
And point of care A1C, if I may add, is not used for, di ba may pag nag-screen, meron gan a point of care, hindi siya pwedeng pan-diagnose ng diabetes.
Okay. Noted po, Dr. Roderos. Thank you very much for answering all the questions. So, in behalf of De La Salle University Medical Center, Department of